Um, okay, let's get on with the presentation. Today I'm going to talk about an important topic that everyone would experience at least one time in their lives. It's personal as well as a treating physicians belong to any specialties. I'm confident that you would at least experience or come across patients, those who has had this type of presentations to your practice. So it's not only something confined to field of medicine, but we as a clinician, we are getting a lot of referrals from non-medical fields as well, those who especially come into surgical side with trauma, head injuries, and some of them obviously having their troubles as a result of having a syncope. So it's an important topic that we need to know. I wanted to bring this up as when I was asked to deliver a lecture, because I felt that this is an area where a lot of active research has been going on, as well as despite that the understanding and management, I see some lack of proper workout being carried out. Therefore, there is an area of interest as well as an area of our treating physician and really need to work it out to improve. Therefore, I decided to get this topic to talk about. So my presentations would be based on defining some of the conditions and then taking you through the assessment and the risk stratification, and later I would discuss what some of the common causes for syncope and their treatment options. Before we begin my proper talk, I wanted to give some highlights of some of the things that we would not normally discuss about in and around the syncope. This is a statement given by an American physician, John Ludberg. This is an area people get sentimental, and there's a lot of scientific and philosophical definitions involved in and around the death. And you might wonder why I talk about death too much to begin with my presentation, because you would realize that death and syncope has a direct link. So Dr. Ludberg thinks that the death is not an enemy. Human death is normal, as we all know. We all die. However, the real enemy is actually dying prematurely, and along with having disability, pain, humans suffer, and prolonging of dying. And all the rest is mostly noise. So that's an important statement from scientific perspective as well as human beings. So that brings to understand what is meant by dying prematurely. So according to the WHO definition, if someone dies before age of 70, that is considered as a premature death. So it's a significant global health concern, and so reducing premature deaths is actually an important health goal one should, as physician, we should be focusing on. And moving from that, I wanted to highlight the about the Pulse Day, which is a new initiative brought about by this premier Heart Rhythm Society, European Heart Rhythm Society. The 1st of March of each year is now been declared as Pulse Day to increase the awareness both among health professionals and general population in order to increase the awareness of heart health in terms of heart rhythm. So it falls on 1st of March each year, which is now being commemorated throughout the world. Unfortunately, it's not yet picked up in Sri Lankan's professional bodies, so it's something we need to focus on. So it highlights the fact that 1 in 3 individual is at risk of significant heart rhythm problems. So it tells you the depth and the width of the problem, which we really need to take it seriously. So sudden cardiac death, I wanted to bring a little bit about it, is if someone's died a natural death due to a cardiac reasons, indicated by sudden loss of consciousness. So I wanted to highlight the the sudden loss of consciousness. It's directly related to what I'm going to talk about. So you can see death, sudden cardiac deaths, cardiac arrest. All of these things are basically at the same spectrum. So that's why I wanted to make an emphasis on these topics before we discuss. So you have to realize when we are talking or dealing a patient with who presented with a blackout or a syncope, you have these things should come to your mind, whether that person is at risk of dying suddenly, whether that patient is at risk of dying prematurely. So keeping those two things in your mind would improve your awareness and the need to care that patients precisely and scientifically. So do you know that 3 out of 4 cardiac arrest happens at homes, out of hospitals? Home is a place we consider safe and cared and loved, but death strike in a way that many of our people would die suddenly at their homes. So this is a tragic situation, and even at the most developed country with best medical facilities available, still only 1 in 10 would be lucky enough to survive a out-of-hospital cardiac arrest. So I wanted to highlight the importance of refreshing your CPR skills. It's no longer considered as a medical personnel's skills. It should be a general personal skills. Anyone, every living human being should be able to perform CPR when it's needed. So if someone suffers an out-of-hospital cardiac arrest, the best response is the immediate CPR. And when we come across patients in our clinical practices, and it's saddened to see that even some of our clinical colleagues who had some of the incidents happening to their family members, the way they act on that situation, it tells that we lack so much about our basic training in delivering, or attending first aid care, delivering first aid care to a person who collapsed. So this is an area we all have to focus and improve our capabilities and getting ourselves accredited and trained every now and then to keep our standards up. So if timely delivered, bystander CPR would increase the chance of survival double to triple times. And if a cardiac arrest happened to you, you have to depend on someone around you to deliver the quality CPR. So life depends on the quality of CPR that is being delivered by. So it's important. So this is a give and take scenario. If you have that skill, you could be able to save someone you care, someone you love, someone of your colleagues. We had a couple of experience like that. Our colleagues having cardiac arrest in front of us and survived by proper quality CPR. So it's an important message that I wanted to deliver. So after gaining introduction like this, I wanted to present some of the clinical cases that I have experienced during my career. So this is about 20, all of these cases highlighting the importance of properly assessing and treating syncope. So there's the first patient is actually a 20-year-old male who was having recurrent and brief disease spell in all postures. So all of these words has meaning in all postures, and having disturbed sleeping with chest tightness and nocturnal sweating. So he is having some evidence of some form of a rhythm issue going on and evidence of autonomic activation. So he denies having any significant past medical history, family history being fairly all right. He had many ECGs done. Spot ECG is only demonstrating sinus tachycardia. Then a Holter was ordered, and this is what has demonstrated. Don't know whether you can see. So this gentleman had what we call ventricular standstill. That is where the AV node of the heart is it's a pump that powers on electricity, has its own electrical circuit, the sinus node and the AV node and the conduction system. All of a sudden, the AV node gives away. There is no ventricular contractions. There's only P waves. So he's virtually going into cardiac arrest and recovering from it. It has been going on. Had it been going on for some time, he would have ended up being dead. So luckily this was picked up in the Holter. So his presentation was recurrent syncopes. Not even syncopes, actually, brief spells. So his heart stopped, ventricles stop pumping blood for few seconds, and then it recovers. So he was immediately offered a pacemaker. He's now doing fine. And this is one of our a colleague. He's a house officer, Jinenov's house officer, had us blackout during labor room duty, and we all know the labor rooms are busy, and we might not be able, often forget our meals, and hydrations are poor. So this was all attributed to a common fainting attack. He, like, jolly well quickly recovered from having a brief syncopal episode. However, he was decided to monitor. He was admitted to his own hospital ICU, and Holter was hooked in. And this is what was recorded on the Holter. He was developing, getting PVCs, and those PVCs was initiating polymorphic VT, and he went to ventricular fibrillation. And one way he was very lucky, the other way he was very unlucky, because nobody in that ICU had picked this up, despite he was connected to a monitor. And he was in VF. Luckily, his rhythm recovered on its own after 2 minutes. This is a real scenario. And he had, luckily he did not have much of a ischemic brain injury, but I don't think he could complete his internship. So these are sometimes these seemingly trivial presentations, and we tend to often ignore them, and sometimes we exactly don't know what is going on. So it's important to take each and everything, even trivial episodes of blackouts or fainty funny turns seriously, and get them investigators. You might pick it up 1 in 100 or 1 in 1,000, but still worth because the danger, the damage it can do to a person's life, we have to take it seriously. So the third patient is actually a 17-year-old girl who was having recurrent blackouts and brief unresponsive episode and rigidity at classrooms and school. This was happening in a school. So it was treated actually as an epileptic fit. Spot ECGs, echoes, Holters, even the EEG was normal, but she was treated as an epilepsy because the people get confused with this. So blackouts and having unresponsive episode with rigidity. So she was having muscle symptoms and tonicity. So we all caught up in labeling this as an epileptic fit. And however, we decided to do a tilt-table test. I will talk about tilt-table test in time to come. And you can see at one point during the tilt, she went into complete asystole. So this was tilt-induced asystole. What was actually happening to her is she's having severe reflex syncope. So sometimes the brain itself can kill you in one way of stopping your heart. So it's called reflex syncope. We will talk about it. So she was complete asystole on the tilt, and that's why there was no cardiac output at the time. The brain was not getting enough blood. And when this happens, normally our people, they don't know what to do. What they do is, even if a person falls down, what they do is they go and lift the person. They are doing completely contradicting things. And so she was put immediately down, and she recovered without any, she was given atropine, I think, You can see the rhythm is slowly recovering. This fourth girl who came to us very recently, she was about to get married. Her wedding was planned on a week after Friday. She came with this thing. She was diagnosed with patient with mitral valve prolapse, but having mitral valve regurgitation as well, coming with recurrent pre-syncope and syncopal episode. She came all the way from a distant place carrying this Holter report. And so this, you can see that she is about to develop like polymorphic VT. So this is called malignant mitral valve syndrome. It's a new entity that has been picked up by young people in their 20s. We had several cases, 2 cardiac arrest, and we immediately gave her ICD trying to preserve her wedding. Unfortunately, we failed on that. They decided to call off the wedding. So from that, let's we talk about transient loss of consciousness and syncope. So consciousness is a complex topic. People, scientists, spiritualists, and philosophers still debate as to what consciousness is. Consciousness is a complex state of awareness that includes perception, cognitions, and responsiveness. So so that tells us that transient loss of consciousness means the state of real or apparent loss of consciousness with loss of awareness that normally encompasses 4 key features. The person normally be amnesic for the period of loss of consciousness. Understandably, the brain does functions ceases, and that normally accompanied by abnormal motor control, and person would become unresponsive for the moment, and normally as it defines, it's short lasting. So if you come across a patient with transient loss of consciousness, this broadly basically we could diagrammatize into non-traumatic and traumatic transient loss of consciousness. So remember our surgical colleagues, if some neurosurgeons, orthopedic surgeons, when they come across patients with surgical issues, especially fractures, head injuries, some of them appears as traumatic loss of consciousness. We normally label them as concussions. However, you might want to take deep, very thorough history taking, because sometimes they might be actually having non-traumatic T-locks and having themselves injured as a result of the fall, or even sustain road traffic accident. So it's an important thing to be aware that our surgical colleagues are good. They are referring neurosurgeons, our orthopedic colleagues, they are referring all sorts of ECG problems because they are aware that these things do exist and not to miss out. So that takes us to define as to what it meant by syncope. So syncope is a sort of transient loss of consciousness that was pathophysiologically due to cerebral hyperperfusion. That is the characteristic pathophysiological reasoning. So it's normally a rapid onset, lasts short duration, and it should recover on its own. That is where the cardiac arrest and syncope differ. In a cardiac arrest scenario, unless someone intervenes and resuscitate that person, that patient consciousness would not recover. Whereas syncope, even if you do not intervene, it should recover on its own. That is where the distinctions happen. So let's go back to a little bit of physiology. So as we know that the systolic blood pressure is a product of related to the cardiac output and the total peripheral resistance. So reduction in cardiac, either in cardiac output or total peripheral resistance, or in combination, should give rise to a blackout. So there are some figures that if heart functions ceases for 3 seconds in upright position, the brain's ATP would run out and the person would experience impairment of conscious level. So if the heart stops for at least for 3 seconds, this is general rule, there can be variations. And this might even change if you lie flat. So that's why people, those who have developed rhythms problems during sleep might not even complain because they may not aware about as to what is happening. So generally, in an alert person who is in upright position, if the heart stops for 3 seconds, they should experience a blackout. Or if the blood pressure drops to certain values at the brain level or the heart level, systolic blood pressure drops, the brain does not get enough perfusion, so the patient would experience a pre-syncope or a blackout. So this is just a simple theory. The cardiac output drops in rhythm failures and pump failures. So rhythm failure, we know that there's a group of people who develop bradycardia not primarily due to a heart rhythm issue, but from the influence coming down from the brain. That's called reflex bradycardia. We talk about cardio neuro inhibition. We'll talk about it in time to come. And then you have your intrinsic bradyarrhythmias and tachyarrhythmias. They all cause drop in cardiac output. The pump fails with obstructive structural cardiac issues like aortic stenosis, mitral stenosis, hypertrophic cardiomyopathy. And do not forget, pulmonary embolism is a well-recognized cause for blackouts. So if you come across a patient who develops blackout, make sure that you rule that out as well. And simply the volume depletion. So total peripheral resistance drops in some of these situations. Normally, in reflex scenarios, both drop in cardiac output as well as drop in total peripheral resistance could happen together. So it leads reflex activity coming down from the vagal stimulation, in simple terms, due to various triggers could cause vasodilatation. And then arterogenic vasodepressors, like all the antihypertensive medication that we give to our patients, and autonomic nervous system failure, primary autoimmune pathologies. So in many occasions, syncope is heralded by more than one mechanism. They might be having more than one mechanism. So normally there's a strange phenomena, what we call two-hit theory. Our bodies are capable of handling one dysfunction at a time. But if you get a second on top of the first one, generally our defense mechanism, reflex mechanism, regulatory mechanism fails and the patients manifest with symptoms. So it's like there's someone who's having a bradycardia, but the body is compensating. But if they become dehydrated due to some other reason, so that regulatory mechanism fails, compensatory mechanism fails, and patient manifests as symptoms. So conventionally, syncope is categorized broadly into three: that's cardiac syncope, reflex syncope, and orthostatic. This is a slightly outdated concept, but still worth considering. Normally, the contemporary way of stratifying syncope is as cardiac syncope and non-cardiac syncope. So we discuss these things. Cardiac syncope occurs as a result of primary rhythm issues, the structural cardiac issues like valve issues, and obviously the great vessels, where we talk about pulmonary embolism, even aortic dissections. Non-cardiac syncope has two subgroups where they develop reflex bradycardia not due to primary rhythm issue, but as a result of autonomic nervous system stimulation, the vagal stimulation from the brain. So there is a group of people who we call orthostatic reflex syncope, which can be reproduced by doing a tilt table test. And there's another group of people who develops bradycardia due to carotid sinus syndrome. And there are various other subgroups where people become bradycardic due to the certain circumstances. Especially you would appreciate that the visceral organ stimulation or irritation can give rise to reflex bradycardia as a result of vagal activation. Then there is another group of non-cardiac syncope where the hypotension becomes the predominant pathology reason. So there's a group of people who are constitutionally having low blood pressure. Then as a result of we intervening patients, we see this happen often than you think. We see some of our patients have actually come for the consultation. They have what we call reactive hypertension or the white coat hypertension. Their blood pressure, office blood pressures are relatively high, and we were misguided by this fact, and we start them on antihypertensives. Later they become hypotensives, so drug-induced hypertensive. And that other group of people would come with intermittent hypertension, which was initially called as orthostatic hypertension, where they develop a drop in blood pressure when changing the posture. And there's another group of people, they develop hypotension as a result of vagal stimulation. It's called reflex hypotension. So as I highlighted in the first few slides of my presentation, there's a causal link between the syncope, the blackouts, and out of hospital cardiac arrest and death. So it's a significant, serious medical issue that we all need to create a better public awareness to improve and quality of care that we deliver. And we should be able to involve the public health and non-medical personnel into this management, unless we won't be able to have a strong hold as to bring down the mortality or the morbidity associated with these type of conditions. So we are in the era of personalized practice of medicine, and as a core feature, we will have to involve our patients and their families into our management. So syncope is a very prevalent condition. It actually make up to 3% of emergency department visits. And cardiac syncope is one-fifth of the time is the cause. Reflex syncope is the commonest one. It could go as high as 60%. And there's always some of these syncopes that are recurring and leading to recurrent hospital admissions. It leads to significant injuries related to having a fall, and it might cause actually up to 12% of fractures might be caused by having syncopes. And you could see that it's common in young people, mainly due to the reflex syncope, what we call common faint, and the prevalence goes down as we hit our mid-40s, and then again there's a steady rise in the prevalence. Anyway, cumulatively, as we grow older, we are far more likely to suffer from a syncope. So this is the important thing. Approximately 1 in 3 to half of the general population, this will tell the burden of the problem. So some of you all will get a syncope in time to come. So as I mentioned earlier, syncope and cardiac arrest. So syncope can precede sudden cardiac arrest. So it's monitoring or treating and assessing these patients. So to present with syncope is utmost crucial step towards preventing or identifying undiagnosed or even diagnosed and cardiac issues, and stratifying them accordingly and treat them to prevent having a out of hospital cardiac arrest. So in the West, I don't know the situation in this part of the world, the Western world, 1 in 5 patients normally die suddenly as a result of ventricular tachyarrhythmias. So most of them, they present with transient loss of consciousness one time or the other. And as the gravity of the problem is, however we advance, we are still far behind to prevent or save a life after cardiac arrest. Even in a hospital setups, we sometimes fails to save a life. So the prevention is the best strategy. You can see that if you sustain a syncope, your dying from any cause it goes up. And if someone suffers if 100 people suffer a syncope, at the end of the 1st to 4th week following the syncope, at least 1 person would be dead, and another 3 people would have some serious complications. You could understand, so syncope is just a marker. It's actually syncope is a manifestation of failing the compensatory mechanism of the body to maintain the consciousness. The brain is the top priority. The brain blood supply is cut off. That's how the syncope comes out, set about. So it indicates that our compensatory mechanism in the body is failing. So it's an important risk factor, important warning that everything is falling apart. So we have to take it very seriously. So any form of syncope, if we follow up them, you can see that they tends to live shorter than their counterparts, those who do not have syncope. So this is a very important slide I wanted to highlight. If you take 100 people who suffer syncope, you could appreciate that only half of will come to medical attention at best. This is not in Sri Lanka, this is in US. So even the most developed world, the syncope is not so taken seriously, even by the physicians, the primary care physicians or the first responders, and only a 1/5 would get referred to a specialist evaluation. And people who suffer syncope, only very few would decided to go for emergency department to get it sorted. Most of the time they come to the hospital or seek the GP next day. They are not going to come immediately rush into the emergency department. So it tells the severity of the problem. It tells the lack of awareness about the problem, and not only among general population but among us. So there are few conditions that can get confused with syncope. I'm not going to talk about too much. So seizures, pseudosyncope, catatony, hypoglycemia, all these conditions can, some other neurological condition, vertebral-basilar TIAs, carotid TIAs, subclavian Steele syndrome. So there could be several other differential diagnoses when someone presented with the transient loss of consciousness. So by definition, hypoglycemia does not fall into transient loss of consciousness, because the pathophysiologically, the transient loss of consciousness is when the brain does not get enough blood. So hypoglycemia is different, so it does not fall into the same category. But people get confused because when someone suffers a blackout, their peripheral perfusion is reduced, diminished. And as a routine, we check the blood sugar. We finger prick at check the blood sugar, and most of the time you would find them having hypoglycemia because of the poor peripheral perfusion or the underperfusion. So, and it might get labeled as hypoglycemia. That is where people go wrong. So just remember the fact that if the blood pressure is low, the finger prick sugar might be spuriously low. So that does not rule out the possibility of a true transient loss of consciousness as compared to a hypoglycemic episode. So we'll take from here to discuss how do we approach a patient who present with a transient loss of consciousness or in broadly syncope. So we have 4 questions to answer if someone comes with it. Was this event a first question we need to ask from a medical standpoint of view? Is this a non-traumatic transient loss of consciousness? So even a patient who suffers injuries, we have to find out whether that is truly traumatic or non-traumatic transient loss of consciousness. Then if it is a T-lock, what is the possibility of it being a syncope? Because there are so many other differential diagnoses for transient loss of consciousness. The main one would be epilepsy, and epilepsy and syncope surprisingly have common features, because in epilepsy, it's a primarily electrical disorder of the brain. In syncope, the secondary electrical disorder of the brain happens as a result of the hypoxia. So that is where things get confused. And if it is a syncope, then we need to determine, is it cardiac or is it non-cardiac? Then is there any evidence to indicate that the patient is at higher risk of having cardiovascular adverse outcome or death? So in briefly, taking a detailed history is the utmost important thing. It's not so easy to get a history from our people, because our people, I mean, you might know this by now, So they have their own versions of interpretation of everything. They say, come and to us say various terms, they are lay terms, colloquial terms, but it's our job to, dig it deeper and try to get a better history. It's not so, history taking is a very difficult task our people are not used to elaborate themselves. They are not good. They are not used to, come out with each and every detail. So it's become our responsibility to dig deeper. So get as detailed as possible about the present event. I normally start with what were you doing? So I wanted to get what was the posture they were there, what were they. So I'll start even from the day, time they wake up. So try to ask them to deliberate as much as information, as much as of event that leading up to the index incidents. So what were you doing? What did you feel exactly before and after? So all kinds of, you might have to lead them. They're not going to come and tell you exactly what happened. You might want to lead them and ask direct questions. And make sure you ask about the intercurrent illnesses and the circumstance of the event. And if you are lucky, get an eyewitness account. And now CCTV cameras are everywhere. You might want to check the CCTV cameras as well, sometimes. And most importantly, previous attacks and history of so-called label fits. Ask about road traffic accidents, ask about drowning incident, ask about drop attacks. All these might be, there could be some hidden things related to syncope. So one person might be ended up having sustaining a road traffic accident as a result of an arrhythmia. So you need to ask those details as well. And past medical is important. Special emphasis should give to taking a detailed cardiac history and family history of syncope, family history of cardiac ailments, and premature and sudden deaths. All of these are important piece to resolve the puzzle. And so syncope is like a detective story. It need a lot of digging and finding out a lot of circumstantial evidence because sometimes the obvious reason may not be as evident as one would expect to be. Occupational history is important, recreational activities, all of this is important, and thorough physical examination. So first, we need to determine is this a T-lock, or if it is so, is this a syncope? So we discuss about this. So it's always, in medicine, it's very unlikely that we get something very straightforward pathognomic. So it's always probability. So we have to keep our minds open, think laterally, think deep, and try not to commit yourself to one particular thing, because it's quite, the apparent picture could be quite illusionary and you might get deceived and fooled. So there's a long list of things that you can gather from the history. So you could see how detailed one has to take a history when it's come to a person who is presenting with a blackout. And all these clues can give rise to, pointing toward one particular direction. But you can appreciate that there are a lot of overlaps. There's no one single feature would determine or tell you exactly this is this and this is not. So you have to ask triggers before an attack and during attacks, eyewitness accounts, how did they fall, and so all kinds of detail. You can appreciate that. But there are a few high-risk features if you can remember these things. If someone presented with a syncope event and having these 4 features, that will tell you that this patient is at higher risk of something sinister going on. So if someone is having new onset chest pain or chest discomfort, take it seriously. If a syncope occurs during exercise or upright supine position, lying flat, take it seriously. And if that patient tells you that I felt faintish with the rapid palpitation, take it seriously. And that patient had a blackout having no warnings beforehand. So that should be taken seriously. Or if there's a family history of sudden cardiac deaths or family history of multiple cardiac issues. So if you have those 4 features in your history, take it seriously. And if going to the past medical history, if you have a person who is coming with long history of recurrent syncopes, very unlikely to be cardiac in nature. Generally, cardiac syncope, you wouldn't have that much of life to live, should it be truly a cardiac issue. And absence of cardiac issues, so that's pointing towards something not so sinister. And those who have a cardiac history, always, if someone having cardiac history, how trivial they are seeing funny turns or black cow, whatever it is, take it seriously. And during physical examination, if you find the blood pressure is, systolic blood pressure is low, less than 90, and is there any evidence of GI bleed or anemia, and if the patient is persistently bradycardic, less than 40 beats, they need all be investigated thoroughly, and they should be admitted on that admission, should not be sending home. So keep in mind, all these syncopes, they are more prone to happen or can even be more senior in the presence of several other factors. So vasoactive medication, your hypertensives, beta blockers, calcium channel blockers, influence of alcohol, and if you are dehydrated, you are very likely to develop syncope even from cardiac point of view. And having respiratory diseases, environmental conditions like in the hot weather, and if you are anemic. So so keeping those things in your mind as well when you come across a patient. So clinical features, there are a few clinical features. So in a way, if you put this together, you can see that someone is having long history of blackouts from their childhood, somewhat unlikely to have a cardiac syncope. And all these having triggers, you have a clear trigger, prolonged standing, during a meal and after a meal. So all side of being in a crowded place. So they all indicative of a non-cardiac syncope. I mean, none of these things are 100% specific or sensitive, but general as a general rule. So while just after standing after exertion, so posture change. So you can see that if someone develops a blackout or a pre-syncope with the posture change, it indicates something autonomic or non-cardiac rather than cardiac. So the clinical feature that you should look for that might indicate that there is something cardiac going on. So during exertion or in supine position, sudden onset palpitation, we've discussed the same thing, the family history. So having any history of cardiac issues, take them seriously. And ECG findings. So I'll bring down some of the ECGs for you to see. So can anyone spot this? Don't know whether you can see it. So this ECG shows patient is sinus rhythm, left axis deviation, right bundle branch block. So having what we call bifascicular block. So if any ECG changes, take them seriously. So various kinds of AV blocks, PR prolongation, first degree, second degree, So that indicates clear cardiac causes. So this patient is having, you can see, premature ventricular complexes. This is called quadruplet happening. So this might itself not be causing syncope, but having this thing indicates that the patient is having a tachyrhythmic problem going on. And I don't know whether you can appreciate it. This patient is a patient with mitral valve prolapse. That patient is having a PVC occurring right on top of the T wave. That's called short couple PVC, very malignant. This is a papillary muscle origin PVC occurring right on top of the T wave. This is the pathophysiology, the pathological culprit for sudden cardiac deaths in mitral valve prolapse. It's something new that has been recently, described. You can see this patient is having mildly bradycardic, having like diffuse T wave invasion. So these are indicative of something cardiac. don't know whether you can appreciate this patient is WPW, pre-excitation is there. This must be easy. It's demonstrate spontaneous type 1, the covert type of ST segment elevations in V1, V2, Brugada pattern. Recently, I had 2 patients back to back, one 21, another 22. We never even think one person died from Brugada. The other person survived the cardiac arrest, 21 and 22. This is a QT prolongation with abnormal T waves. So, and this is what we call short QT interval. So it's very important that we assess our ECG systematically, unless you would miss any. So it's another topic for a different day to discuss about ECGs. I'm just highlighting so whether you can have this is called short QT. This is called early repolarization syndrome, subtle ST elevation in 2-3 AVF. So these are all arrhythmogenic pathologies. So moving from that, now once we get a patient having, after going through all kinds of history taking examination, if you are lucky, you might find a very evident cause for your patient's syncope. Most often it is not the case. So you have to think deeper and dig deeper and plan your investigation. So basically, in terms of management perspective or in terms of assessment, one would, this is a kind of algorithm one can run in their minds. So you have one end, the cardiac pathology. You have at the other end, the non-cardiac pathology, which is normally driven by autonomic phenomena. So you can plan your investigations. So if you feel like your patient is having cardiac line, these are the sort of investigation you should be carrying out. Focus on doing the imaging to assess the cardiac structure. That includes the echocardiogram, and now we have like more advanced stuff like cardiac MRI, CTs, coronary angiogram, so all kinds of structural and coronary assessment, valve assessment. And you would require ECG monitoring, like a spot ECG would not rule out anything else. And make sure when you have to ask when you have a patient coming to you and with an ECG, ask whether that is what was the time that ECG was taken. Some of these patients having symptoms, they are very brief, and ECG was taken next day. So that ECG, the normal ECG might not tell you anything about it. So that is called symptoms ECG correlation. And so you have to plan a lot of other investigation. So if you are like confident that this is not cardiac, then you have to work your line on autonomic system. So on the other hand, there are a few some characteristics that might tell you that this may be not so pathological or a sinister syncope, which we call low risk category. But most of the time, you would not. This is not so easy. So you might have to, split your hair and carrying out investigation from both ends to come to a reasonable conclusion. So ambulatory rhythm monitoring and ambulatory blood pressure monitoring, we've discussed about this. Some of these patients require still table test, carotid sinus massage test, and make sure that you run some of the blood investigations as well. So hemoglobin level, saturation, troponin levels, D-dimers, and endocrine opinion as well, to make sure that there's no endocrine cause for blackouts as well, like Addison's. So rhythm assessment, so it could appreciate that depending on the frequency of the symptoms, you have to plan how prolonged we need to do the rhythm monitoring. Unfortunately, some of the things are we don't have at best we can do only 72 hours Holters. So we are very likely that our Holters are missing important clues that indicate cardiac pathology. Depending on the frequency, we don't have implantable loop recorders. They are so expensive, 1.5 million a unit. We don't have them. We don't have 7 days Holter. We don't have event Holter. But luckily, some patient would now use smartphones and Apple phones. They are quite capable of monitoring their rhythms. So it's an important tool that is becoming popular to recognize heart rhythm issues, smartwatches. So the theory is that you have to establish the symptoms ECG correlation. So when you are analyzing ECG or a Holter, make sure that you ask the patient history. If you see some event on the and ask what was the symptom. So we have to build the symptoms ECG correlation in order to interpret an ECG. So we basically discussed these things. So if you are suspecting rhythm assessment, there are various other invasive tests that you can do, and if it's structural assessment, so kinds of thing. So if a patient is suspected of having non-cardiac syncope, then the first what you need to do is at any patient, you take a history, you do a ECG, and you do blood pressure active standing. So you take a blood pressure seated supine position, and then you ask the patient to stand up and stay standing for 3 minutes, and then you take another blood pressure and a heart rate. So, and then if those are not indicative of anything, as we mentioned, the non-cardiac syncope, there is 2 arms. There's reflex brady path and a hypertensive path. So what you do is you do your short cardiac autonomic functional assessment that encompasses doing a tilt table test and a carotid sinus massage. So part of it is actually active standing, and so we have these things we can do, and doing your ambulatory blood pressure. So these are not like a proper autonomic assessment done by the physiologist. This is sort of a crude way of assessing the blood pressure and the heart rate response to an orthostatic challenge. So as we know that we humans have evolved, in our evolutionary process, we gave up, freed our hands and stay on our feet. So brain is at the top, the heart is in the middle, and half of the body underneath, and the gravity is pulling everything down. So we are changing posture. So brain is constantly at a challenging position to make sure that the brain gets enough blood. So brain manipulate body organs, including the heart and the vasculature, to make sure that the brain gets enough blood supply to function. So as we change our posture, the brain is constantly challenged, and the brain has to adjust the heart and the vasculature to make sure that the brain gets enough perfusion. So this can be tested. That's why this common faint or the vasovagal syncope is not seen among animals. It's only seen among humans. So we believe it's a maladaptation of our evolution. So that is where we do the active standing. So we check the blood pressure and heart rate in supine position and ask the patient to stand up and stay for 3 minutes. And then we take the measurements. So depending on the response, so there can be various responses. And tilt table test is what we do it in our test. It's a motorized table test where patient can be, likely securely fastened into a table, and that table is motorized. It can go up and assume a position tilt of 70 degree, and patient is connected to a continuous rhythm monitoring and a blood pressure monitoring. In some centers, obviously, it is combined with an EEG as well. Especially those who develop epileptic kind of picture as a result of the syncope, they have EEG facilities also available. So I'm not going to go detail on describing how to do a tilt table test. So it's a procedure to follow, and this is the response we get. So what we do is we put the patient supine position, take pressure, and allow the patient to settle on the tilt table test, and then sometimes we use other provocative things like giving GTN, and then we bring the patient up to a 70 degree position and keep on recording blood pressure and the heart rate. And this is the body response normally. And if someone to develop a blackout, but that is what happens, the heart rate coming down, and all of a sudden the heart rate started to drop. So this is something the brain does. It's not something heart does. It's something the brain does. What actually happens is the brain is not getting enough blood. The brain is trying to manipulate the body system to make sure that it is going. That's why there you feel you are prodrome. You're feeling not good. You feel nauseated. You feel funny, and you feel your heart is racing. So brain is trying to compensate for the orthostatic challenge, and failing which the brain induced the blackout. So the person who is in upright position, if you induce the blackout, what happens? That person falls down, and brain and the heart comes to the same level. That's so brain is doing the thing in order to make sure that brain gets enough perfusion, but on that process, the person sustain a fall and get themselves injured. So that's why we believe it is a part of a maladaptive thing in our evolution. The same thing. So carotid sinus massage is carotid sinus is in somewhere in the bifurcation. It's vaguely innervated. So in some people, when we massage the carotid, we used to treat this same thing for arrhythmias. The same way, some people, this carotid sinus can be extremely sensitive, and even slightest manipulation could give rise to significant bradycardia. Especially this happens common in elderly people. Sometimes they come back out with when they try to tighten up their tie, or during shaving or during head turn, this gets compressed and person might present with a blackout. So this is called cardiac inhibition. You can see when we perform the carotid massage, you can see the heart rate slows down and the blood pressure crashes. And when we give atropine, it reverses. So this is a vaguely mediated process, not something to do with the heart conduction system. Heart conduction system can still be perfectly fine, but due to the vagal stimulation, the patient can develop bradycardia. So when you come across a patient with bradycardia, it does not necessarily mean that the heart electrical system is at a fault. It could be, that's why we call it extrinsic bradycardia or reflex bradycardia. So we talked some of the things. So reflex syncope is one of the commonest cause for non-cardiac blackout. We don't know why it is there. We believe as a maladaptation of our evolution. It's a person who's losing consciousness due to a neural reflex mechanism coming from the brain. It involves patients developing either bradycardia or hypotension as a result of vagal stimulation due to various reasons. So all the mechanisms are not yet fully understood. It is driven by central hypothalamic center and involving the vasomotor center through the vagus nerve mainly, and it receives impulses from various visceral organs, GI tract, respiratory tract. That is why we have manipulation of vascular system, internal organs, all these procedures giving rise to blackouts. It's how this happens, and some people, there can be central higher cortical response as well. That's why some people develop blackouts due to emotional triggers as well. The commonest is the vasovagal, what we call, or the orthostatic reflex syncope, and we don't know exactly why it is there and what its purpose, but it is there. Sometimes it can be quite challenging and harmful to the person, those who have it. Any one of us can get this thing. We all have various different thresholds. Some people are far likely to develop reflex syncope, but others, even in extreme scenarios, any healthy person can develop a blackout due to a reflex syncope. So this is normally the cascade. You have a trigger or pain or dehydration, anything. It leads to autonomic activation, leads to vasodilatation and bradycardia. Then it causes the blood pressure to crash. The cerebral underperfusions occur and the patient loses the consciousness. And as we have a fall, when the blood pressure, the perfusion improves, the patient recovers. And this can get as dramatic as if you feel like you are losing your life. So this can get as dramatic as what it can be. It can be a very frightening experience. So there are various types. So it's a common problem. So you remember I showed this before. So you can see it's especially young people. This is the commonest reason for the blackouts in young people is the reflex syncope, which is considered benign, but I have seen people ended up having troubles, having to sustain a lot of injuries. So I'll rush this through and we'll get back to the interest of time, the management, how to treat syncope. So we have a couple of goals to achieve. So our primary goal is to reduce the recurrence and relevant impact to the patient. To patients are feared as to what is going on in their lives, and so we have to alleviate their fear, and in order to allow them to function as normal as it can, and patient should be involved in the decision making process, and our ultimate goal is to reduce the sudden cardiac arrest and sudden cardiac risk. So this is an interesting thing, that the thorough evaluation itself reduces the syncope prevalence. That's an interesting thing. They have noted even recurrence rates drop to 50% if you do a thorough assessment of a patient who is present, because many of these things are reflex syncope rather than cardiac. So that itself, reassurance that you give to your patient would have a placebo effect and improve the minimize the recurrence rate. So cardiac syncope, very easy. So if you have a Brady component, you give them a pacemaker, and then if you have a tachycardia component, then you give them either do catheter ablation or medication, or if the SVT is the problem, you do offer them a catheter ablation. If a VT or a ventricular tachyarrhythmia, other than the medical treatment, catheter ablation, you have to give them a implantable cardioverter defibrillator to make sure to minimize the risk of sudden cardiac death. When it's come to non-cardiac, as we discussed earlier, so there's two group basically. There's a Brady component, reflex Brady group, and there's a reflex hypotensive group. So if your patient is having high blood pressure as well, then you have to adjust your medication, time the medication, and changing short-acting medication to long-acting medication, postural exercise, or all kinds of measurements to minimize the drop in blood pressure, iatrogenic drop in blood pressure. And some patients develop, some of the, especially patients who have psychiatric illnesses who are on psychotropic medications, they frequently come with postural hypotensive episodes. So you have to discuss with the relevant specialist and alter their medication to minimize it. And obviously, you can give some of the vasoactive medications like fludrocortisone. It's an aldosterone agonist, and midodrine, which is an alpha agonist, to improve the perfusion and improve the peripheral tone. Fludrocortisone will expand the volume and improve the circulation to minimize the postural hypotensive episode. When someone is presented with the reflex Brady episodes, if they are younger, we try to not to give them a pacemaker. We try to manage them with sympathomimetic. Theophylline is a very good medication, to be honest. Terbutaline, theophylline, salbutamol, ocyprenolene, all of these work. And there's a novel treatment option called cardioneural ablation, which we don't have. We can go inside the heart and ablate the vagal inputs into the relying ganglia that are located inside the heart. We can go them and ablate and cut off the vagal stimulation to the heart. And even some of the AV blocks can be now cured without giving them a pacemaker. And if they are especially above 60 and having Brady episode, we normally go ahead and give them a pacemaker. So reflex syncope, so as we know, it's a very common problem. It takes a huge amount of our work time. We get referred many patients with reflex syncope, and it's not a sinister, considered as a sinister, but I've seen people ended up in troubles. I had one patient falling into a well. I had few patients falling off the cliff of a roof. One person had a fall from a top of a tree, and one person had fall into open fire. So even though how trivial it is, according to the circumstances, you might get into big troubles. It's important to take or any of these syncopes seriously and treat them. So these are the kind of advices we give them. Normally, reflex syncope, before they culminate into a full-blown blackout, they have a period of having symptoms called prodrome, where they feel not well about themselves. They feel nauseated, they feel funny, they feel lightheaded. That is the point. They need to recognize the symptoms and change their symptoms. So suppose someone is getting a blackout, known to get a blackout during a vaccination. So what they need to do, they need to put the patient on a supine position and do it like that, taking measures to prevent that happens. And if you're about to get it, most of the time you have time to act on it. So advise them to recognize it and take proper measures. So what they need to do is to change the posture and lie flat. That is all need. If someone is near them, what they need to do is they need to bring their legs up. So the mistake our people do is, instead of raising the legs up, we raise the patient from the top, making it worse. So that is where our knowledge is lack. We should be able to, if someone found collapsing on the floor, the basic reflex should be to check the pulse, check the breathing, and if not, start CPR. So these are called counter pressure maneuvers. If someone is feeling wobbly and dizzy, these are the measures that you can do. It's to improve the circulation by tensing the muscles groups axially to improve the perfusion and to minimize blackouts. You can see that if someone is tensing their arm, it improves the blood pressure and minimizes the blackout. There is a pharmacological options as well to give fluorocortisone or midodrine. This is what I was talking about, the cardioneural ablations. So I'm coming to end of my presentation. You could do further reading. It's a very good article, 25 years of research on syncope, which was published in Europace 2023. And I have very simple take-home messages. Check your pulse, know your CPR, and take your patient syncope seriously. That is all. Thank you.